talk.
Yes.
Okay, this is I want to talk about the advantage of the UKA. Today, my talk is
Yeah.
focused on the ACL. So, of course, okay, okay. I also do, as you know, the astroscopes. So, ACL is important. I think I already show you this photo. In the morning, I reconstruct the ACL arthroscopically, but in the afternoon, I cut the ACL to do the TKA. It's very sad thing for me. So because I understand the ACL is very important for knee function and knee kinematics. So I focused on how to retain the ACL. This is quite important. So because in the UK, I can retain ACL. So I do the UK as many as possible. In the country, I do the UKA. Around 6% of patients in my hospital. So around 10 years ago, I went to the Oxford to learn more about the UKA for 6 months. So because UK is very technical demanding operation. So I wanted to know more about UK for knowledge, skill, theory, and many think about this. So I went to the Oxford and learned from Professor Murray, David Murray. He is now the leader in the world of Oxford News. And I joined the operation and learned a lot. And I also learned about rehabilitation and the physical examination from the therapist. And I have some research. I done some research regarding the UK. And during this work, during this period, I published the one paper. Oh, it's a very fantastic period to the experience. After that, so my percentage of UKA increased up to 6%. I believe UKA is a very good operation. So the advantage is the first thing is the low invasion, I said yesterday. And in the same time, so not only the low invasion and the deeper correction, it is also beneficial for the patient, especially for the Asian countries. And this ACL. ACL is quite important. So I'm very interested in the ACL status for the patient undergo the arthroplasty. So I evaluated around to 1,050 patients, 500 patients, and evaluated the status of ACL. I roughly classified the status of ACL. In my hospital, around 30% or 80% patients had the intact functioning ACL. It is surprising. So how I did the operation for such ACL functioning patients. So I had 1,020 years ACL that knee had ACL intact. Well, I did the UKA for the 71% patient, but around 30% patients had the functioning ACL at the time of the operation. But I did the TKA. So it means I sacrifice around 30% patients. The patient has the ACL intact. So I surprising this fact. But of course, it depends on the preoperative diagnosis or indication. But sometimes I find the intact ACL despite the preoperative diagnosis, the patient has the indication of the TKA. But it is my theme is increasing the accuracy of the preoperative diagnosis. So I'm surprised, even in our institution, where the 60% undergo the unique component arthroplasty. So I did the TKA for the ACL functioning needs. So one reason is this is due to the lateral cartilage wear. So one reason for the TKA for ACL functioning need is one reason is lateral cartilage damage. So I also evaluated to the patient and the TKA patient, and I evaluated the status of ACL and the status of lateral cartilage, ACL functioning or ACL deficiency, and cartilage status of the lateral compartment. So also it is also surprising. I did a TKA for the patient that has the intact ACL and intact lateral cartilage. Maybe this is due to the inaccurate preoperative diagnosis. And there is some reason for this inaccurate preoperative diagnosis. One reason is the lateral side disease. Some patients have the lateral, the osteophyte, and osteophyte in the intercondylar notch. I thought the patient has the damaged lateral cartilage or damaged ACL. But sometimes I found the intact lateral cartilage and the intact ACL in the operatively. So if possible, I want to prepare the backup TKA to convert to the TKA to the UKA, depending on the intraarticular findings intraoperatively. But it is not impossible to prepare the backup UKA routinely due to the cost for the preparing. So we need some cost to prepare the backup implant. So it is not always possible for me to, sometimes I did very disappointed when I found the intact ACL and the intact lateral cartilage.
Can't hear you.
Okay. Okay. Can you hear me? I'm sorry.
Hear you. I can hear you.
Sorry.
Okay.
I'm sorry. What I was saying was this one. So this is the absolute indication for UK. This is the absolute indication for the TK. This category is the candidate for bicruciate retaining TK or bicompartmental union arthroplasty. And this category is very controversial. So sometimes I do the UKA for this patient instead of TK because ACL is a low invasive, especially for the elderly patient. In fact, there are some reports of the UKA for the ACL deficient knees. So I have no experience of some problem after the UKA for ACL deficient knee. No loosenings, no dislocation, no wear. But I believe there are two types of ACL deficient OA. There is one type is the ACL deficiency first. Then due to the ACL damage and the subluxation and instability, then the need had secondary OA. This is the ACL deficient first and OA second. Another case is the OA first. Due to the osteophyte of the OA, the osteophyte in the intercardinal notch can damage the ACL, and ACL gradually damaged and finally gone out. This patient is categorized as OA first and ACL deficient second. I believe this type of patient can be the candidate for UKA because in such patients, the kinematics and the characteristic is quite similar to the ACL functioning OA. So some reports show that due to the osteophyte or soft tissue contracture and the anterior instability of the tibia is evident in the patient is the ACL deficient knee. This is the secondary ACL deficiency, the OA first. I believe I can do the UKA in such patients. On the contrary, if the patient has the ACL, damaged ACL, and subsequent OA, such patient is, of course, the first selection is the TKA. But we can do the UK along with the ACL reconstruction. I experienced around 10 cases of ACL reconstruction and UK in the same time. The result is quite good. So it is the good selection for the patient with the OA first and ACL deficient second patient. Anyway, of course, normally these patients are candidate for the TKA, but in the limited case, we can do the UKA or UK along with ACL's reconstruction. So ideally, it is ideal to select the type of arthroplasty intraoperatively. But again, to prepare the backup implant and instrument, we need extra cost. So in the most cases, we should decide the type of operation preparatively. Sometimes it's missed. It's the problem. So as I said before, in my patient, around 80% patient had intact ACL, functioning ACL. So this is not unusual because the most the past study, past report shows that around 70%, 70% to 80% patient has the functional ACL. So roughly saying around 70 or 80 patients who are candidate for the arthritis have intact ACL. So how to deal this? How do you think about this? So one solution is the ACL cut is doesn't matter, but this is for me. This thinking is for me. And I want to retain ACL as much as possible. So I'm always also considering to the ACL even for the patient because ACL is quite important for the knee kinematics. This is a very classical paper. Of course, to evaluate the kinematics, three-dimensional kinematics analysis is quite difficult. It needs some special computer program and some instrument. So it is difficult to do, especially for our the general hospital. So this is a price. He worked in the Oxford University. He measured the patella tendon angle. This is the angle between the tibial axis and the patella tendon from here to here. This angle stimulates the rollback motion of the knee. This is the normal knee is a black line, and the gray line is the patella tendon angle 1 year after the UKA operation, and the dot line is the 10 years after the UKA. It is surprisingly, after the UKA, the rollback pattern is quite similar to the normal knee, even after 10 years after the operation. In contrast, after the TK kinematics, the rollback motion is quite different to the normal and UKA knee. Maybe this is due to the lack of ACL. So this graph shows the importance of ACL even after the arthroplasty. So, and I evaluated the past, just after the operation, I take the X-ray in the lateral view, and like this, the lateral extended knee. So I measured the FT distance. It is the femoral tibial distance. This is the distance between the anterior surface of the femur and the tibial tabercle. Oh, it is also interesting. Only the UKA prevented the anterior motion translation of the tibia. In the other operations, this is the UKA for the ACL deficient knee, and this is the TK, the medial pivot. This is the TK, the CR knee. In these knees, we showed anterior translation. So this is due to the lack of the ACL. So if we retain the ACL, we can prevent anterior motion, abnormal anterior motion of the tibia against the femur. So this is called to the paradoxical motion. And then normally, this is a straight rollback motion. The medial side is not so shows the small amount of rollback, but the lateral side is the much posterior movement. But after the cut of ACL, we call it the paradoxical motion. The initial contact point is here in the normal knee. This is the anterior part of the tibial plateau. But after the cut of ACL, the contact points comes posteriorly. This is some kind of anterior subluxation due to the lack of insufficient ACL. But early flexion phase, the subluxation reduces suddenly. So the contact point move anteriorly, then roll back. We call it this motion as paradoxical motion. So roll forward first and then roll back. The patient will feel discomfort or instability due to this anterior subluxation, anterior movement of the contact point in the initial phase of the flexion. In other words, this is the some kind of mid-flexion instability. This is quite important because in the mid-flexion, we frequently use this angle of the knee. For example, the walking stay up, the stay down, and slope up and slope down. So it is quite important to the mid-flexion stability. But due to this instability, the patient have discomfort and the instability. So it is quite important. If we can retain the ACL, the patient's satisfaction will improved. So it is very famous fact that around 10 to 20% patients are unsatisfactory after TKA. So after the TKA, patient satisfactory is not perfect due to the malalignment or limited allowance. In the normal TKA, the average flexion angle should be 120 degrees. But most patients have the deeper flexion angle operatively. After the operation, the patient knee flexion angle can be reduced. This is one reason for unsatisfactory after TKA. This is a physiological. So that means the patient expectation. The patient can imagine the perfect knee. No pain, no discomfort, no instability. But in fact, the patient have some instability and discomfort and the noise. Some patients feel noise because of the heat or friction between the polyethylene and the metal or in the normal bone. And the functionally, the difficulty in staying up and get on the car. And I think one of the main reasons is ACL sacrifice. So the function of ACL can be the main cause of unsatisfactory after the TKA. So this is a very famous paper. The Jacobs compare the patients after the TKA between the patient had functional ACL at the time of surgery and deficient ACL at time of surgery. So satisfaction is better in the patient that had ACL deficient knee. So the knee that had the functional ACL at the time of the surgery was the worst satisfactory. Maybe this is due to the patient remember the status, the feeling of the knee that had the intact ACL. After the cut ACL, if the patient reduce the pain and the function, but the patient has the feeling of intact ACL. So after the cut of ACL and replace to the ACL, the patient have some instability, just as I said before. That can be the cause of unsatisfactory after the TKA with the cut ACL. Functional score and RM after TKA were worse in ACL functioning knee than in ACL deficient knee. This is another study. So the roughly saying the patient satisfaction is better in the UKA than in TKA. This is of course, there are some reason to compare to the UKA and the TKA. The main difference is the ACL retention. The UK can retain the ACL. This is the great benefit for the UK. They can contribute to the satisfaction of the patient after the operation. So I want to retain the ACL as much as possible. This is the main reason to select the UK in the many patients. Okay, this is the end of my talk. So unfortunately, and so far, UK is available in your country, but again, in the near future, you can use the UKA. So it is, it can be a great chance for you to do the UK. You can be the pioneer of UKA in your country. So now you should learn more about UK. Okay, again, I will upload this video in the YouTube, and tomorrow I will talk about the complication and the revision rate after the UKA. Because after the UKA, revision rate is much higher than the TKA. There are some reasons. So how to resolve this, I will explain tomorrow. Okay, anyway, so this is the end of my talk. Thank you for joining. And
Thank you, sir.
Thank you.
If you have any question or comment, please send me email or message or chat on this Zoom. Okay, thank you. Thank you.
Thank you.